This video will be covering a short review of the anatomy of the shoulder that will be pertinent for this unit. So before we get started, I just wanted to make a general comment about exams of the shoulders and becoming familiar with the shoulder joint. So much of the shoulder and becoming comfortable with the shoulder is going to be simply palpation. And it's going to be palpating the appropriate correct landmarks so you know where you're at, and then knowing the relationships of muscles and ligaments and bones and tendons and bursa and other things in the shoulder, so that when you press on somewhere or you're testing somewhere, right, you're having a person move or do whatever they're doing, so much of what we're going to look at in the shoulder is just knowing the relationships and the anatomy of the shoulder, and then think about what's actually happening there. A lot of people have a tough time initially going through evaluations of the shoulder because there's so much structure. And if our anatomy isn't really good, then a lot of times we have a tough time making heads and tails of the shoulder and the problems that occur there because we don't know what's actually in there when we palpate and when we stress test. So as I go through this, I'm gonna skip over some of these slides fairly quickly, but I just want you to realize and take a moment on yourself or on somebody else. Go through a couple of these palpations in the shoulder so that you can feel like you're comfortable, and then refresh yourself on some of the relationships of when we're palpating, what we're actually touching and what's there. That will help you as much as anything when it comes to the shoulder. So with that being said, we'll dive in here. The shoulder joint, right? So the shoulder joint is made up of this humeral head and where it contacts here on this glenoid fossa. So the scapula and then our humerus make up our shoulder joint. The clavicle is going to come in and attach at the acromion process of the scapula, okay, here. But it's actually not going to contact the humerus, but it does play a role in the motion. One thing I just want to make a note of here, and we'll talk about this in just a little bit. You know, we're just coming out of the hip and the knee, and we've talked a little bit about retroversion and anteversion. One thing I want you to make note of right away, the humerus is 30 to 40 degrees of retroversion inside of this joint. And that may seem counterintuitive to you, but we'll talk about this in a couple slides, but I want you to think about the angle of the scapula and how it comes off of the rib cage. And as you think about that, it might begin to make sense why the humeral head might have this relationship. So just a quick note about that. Go ahead and just refresh yourself on some of these bony landmarks, specifically the coracoid process, the acromion process, that glenoid fossa, the borders, these angles. Just go ahead and refresh yourself on some of those in the scapula. Same thing here at the humerus. Go through and see if you can palpate that greater tubercle and the lesser tubercle of the humerus. Palpate up and down along your clavicle, and then go ahead and move your shoulder up to 180 degrees and palpate that clavicle again. See how it changes. See where it changes. Palpate this, the sternal end of your clavicle as you move through, and you can actually feel a cool articulation. So just take a second and refresh yourself on some of these. Same thing with the muscles here. We've got scapular associated muscles. So these are muscles that are going to play particular roles in the scapula. You can see traps, rhomboids, pecs, major and minor, particularly that minor, right? Serratus anterior, lats, levator scapulae. And then we're going to have our muscles that have our humeral associations. So these are muscles that are going onto that humerus, and they're actually going to cause motion at that humerus. So we're going to have our rotator cuff, sits, right? Supraspinatus, infraspinatus, teres minor, subscapularis. Pec major, latissimus dorsi, coracobrachialis, triceps and biceps brachii, deltoid, and teres major. So those are muscles that are going to specifically play in at the humerus. Quick review on those rotator cuff muscles. Hopefully by now these are becoming this should be straight review. Make sure you're familiar with these actions. We'll talk about these actions, and we'll actually stress these muscles. So make sure you are aware and familiar with the actions of each of these muscles. Getting into our articulations, you can look at the amount of articulations that make up our shoulder joint. That makes our shoulder joint, from a helicopter view, right, from a mile up, our shoulder joint is one of our most, it accomplishes the most range of motion of any joint in the body. But because of its extensive range of motion, we often compromise stability. So look at all of these articulations. So we've got our scapulothoracic joint, so the scapula sitting on the ribs, sternoclavicular joint, sternum to clavicle. This is actually the only true attachment to the axial skeleton, if you go through and think about it, to the shoulder. We've got our glenohumeral joint. This is the one we always think about when we talk about the shoulder. Our coricoclavicular joint, we'll talk about some ligaments there. And then we're going to talk about our acromioclavicular joint. So we've got all of these articulations that are going to come together that allow us to accomplish huge range of motion in the shoulder. But realize, we really lose integrity and stability of the shoulder joint because we've got all of these things contributing to excessive ranges of motion. So kind of an interesting idea, again, just from a helicopter's view from way above. Lots of range of motion, less stability. And that's exactly what we have here in the shoulder joint. Okay, so I wanted to this was the slide. I want to spend just a moment here. So I think that this might be a place that we start to see some new things as far as anatomy goes. So this is specifically at that glenohumeral joint. Keep doing that. This is specifically at this glenohumeral joint. So this is our ball and socket joint where the humerus meets this glenoid fossa. So you can see here we're looking from a lateral view into the scapula. Lots of range of motion here. Lacks bony stability, I just mentioned that. But this might be something you might not know about, the glenoid labrum. So we also have our hip labrum, which we've talked about. This glenoid labrum is going to stick out. You can see it here. The glenoid labrum is going to specifically deepen the glenoid cavity. So it's where that humerus is going to come in and contact that glenoid fossa, and the glenoid labrum sits over the top of that, deepening that cavity, helping provide some stability. However, in the event of shoulder injuries, that this glenoid labrum is a very commonly injured structure because it's not bony, but it's trying to provide some stability. So, there's that trade-off there of trying to provide stability while still not being a bone. So kind of an interesting idea on that labrum. And I just wanted to make a note of that there. And then finally, the rotator cuff. The rotator cuff functions as a unit to really try to stabilize the shoulder by sucking the humerus into this glenoid fossa. So just a few thoughts about that. As I mentioned, so much of the shoulder is palpation. Just, take a look at this slide, go through, palpate each of these. See if you can make heads and tails of some of these things as you go through and palpate. These were those anterior palpations. Here's some posterior palpations. Again, go through and just see as you palpate, kind of think about, well, this is what I'm feeling. This would be here. This would be here. So if a person has pain here, this is what they may be having. Okay, so a couple more. I wanted to come back to this. So I already mentioned that humeral head is 30 degrees in retroversion. And you might think that that's a little unusual because we're just coming out of that hip, and we've talked about how the hip is more, 8 to 14 degrees. However, this is a big reason for that retroversion in this humerus, is because of our scapular plane. So this is often called our scapular plane. Realize our scapula doesn't sit on our rib cage at a 180-degree angle, right? It's not perfectly flat. It sits on these rounded ribs, and it creates what's commonly clinically called our scapular plane, or our scaption plane, right here. So our scaption plane is about 30 degrees, 30 to 40 degrees. So because our scapula is coming off our rib cage at about 30 degrees, the humerus has tilted and it sits about 30 degrees retroverted so that the arm actually hangs straight. And maybe I'll bring some model. I'll see if I can find some models for this so you guys can see how that happens. But I think you can visualize and appreciate it now after our discussions of retroversion and anteversion, that our scapula is going to come off at this angle, and so now our humerus is adjusting so that our arm actually hangs straight as opposed to out or in. So hopefully that can kind of make sense. We have some tipping in this scapula. And then, like I said, please know this idea of scaption, that scapular plane. It actually becomes pretty important clinically, and it's something we talk about. So a few more thoughts about this scapula. You know, we can have a wide amount of variation in the scapula, particularly in the chromion and the coracoid process of the scapula. So these images here can help give you ideas of the amount of variability person to person in their scapula, and particularly in the roof of the shoulder joint. So now you can begin to think, you know, well, if someone's scapula looks like this versus this, what might that do for their overall shoulder joint, right? Hopefully you can see in this scapula, a person's going to be able to get over their head fairly easily. They're going to have excessive ranges of motion, right? It's going to look and sit very easily. Their humeral head will sit in this glenoid fossa very easily. Whereas here in this one, we've got more of this it's a pear-shaped glenoid fossa here. We've got this acromion, which really overhangs, and it even kind of comes to this beak, right? We've got this big coracoid process, which again is extending that roof of the scapula. So, you know, a person that has this type of scapular orientation, they probably have less range of motion. They're more predisposed to impingement here in the roof of the scapula. So, you know, lots of variation in this, and you can begin to think about how this variation would play into potential shoulder pathology and range of motion. Again, this angle of inclination, so 30 degrees of retroversion, 135-degree angle of inclination here at the humerus, so we hang down really pretty straight at the shoulder. There's a little bit more about this here. You can take a minute and read through that if you desire to learn a little bit more about that. I'm going to pass right through this. This scapular tilting and tipping, we'll kind of feel that. And then I wanted to just get to these last two slides here. Typical joint ranges of motion in the shoulder. So most of the time we get to 180 degrees in flexion and abduction, right? Our adduction, that's going to be coming across our body. So you can think as the shoulder comes across the body without us tilting 50 to 75 degrees. Extension, right? So going backwards from 0 degrees, if our arm is straight down, moving backwards, we can get these 60. And then this is these internal and external rotations. So if you put your shoulder at 90 degrees of abduction, it makes it fairly easily actually, and we'll put our elbow at 90 degrees of flexion, and we'll go through and measure some of these internal and external rotations. But you can see the norms here: 90 degrees, 90 degrees, and then our horizontal adduction and abduction. We can see there. This is just a review of what we just were talking about and a review of our concave and convex rule. There's lots of videos on YouTube about how to measure this range of motion. So if you need to go ahead and look through this, we'll also go through this tomorrow in class.